My name is Sheree Schwartz. I co-direct the MACC Hub out of Johns Hopkins, and I'm going to be talking today about the Network for Implementation Science in HIV, or also known as NICHE. I don't have any disclosures. So the work that I'm going to be presenting today, and the concept is really a concept that is born out of many different people and the work of many across the Hub network and the ISKI network. And so I'll tell you a little bit briefly about what NICHE is, and then talk a little bit about what we think is the potential for NICHE as a multi-site research structure to help support EHE goals in advanced implementation science, particularly being able to answer some questions related to the generalizability versus context debate that's going on within implementation science, to be able to think about power in numbers, and to develop and test implementation strategies to advance effectiveness and equity. So NICHE is a pilot of this National Network for Implementation Science in HIV. The idea is that we're drawing upon the hubs across the US and engaging locally across those hubs, using them as sites to conduct implementation science and HIV research, where there's a collaborative protocol, similar recruitment and data collection tools. And we work with the core structure, so we have a qualitative, a quantitative, and a site engagement team. And the goal of this is really to try and generate findings and try and understand what some of the barriers are to implementing evidence-based interventions that are similar across contexts within the US, and which barriers and facilitators are potentially different. So the map that you see here in blue are the EHE priority jurisdictions in states, and you can see layered onto that is where the hubs are located. And those hubs are the sites predominantly for the NICHE studies. So the different colored stars are the different protocols, 001, 002, and 003. And so you see that there's pretty good coverage across this network in terms of representation. And that can even grow when we expand to new hubs. So as I mentioned, there are 3 current protocols. I have the privilege of being the protocol chair for 001, and thus I'm presenting today, but we have 2 additional protocols, and I'll be talking briefly about each of them. And really the joy of this work has been the opportunity to work collaboratively across this network of investigators and really get to start sharing lessons and protocols collaboratively. So for 001, we're working across 6 sites. Our local site PIs are Ade Arana at UAB, Joyce Jones in Baltimore, Russell Brewer in Chicago, LaRon Nelson out of Yale, but working in Dallas-Fort Worth, Jay Lee here at UCLA, and Jill Blumenthal at UCSD. And we have amazing sub-teams led by Nanette Benbow, Laura Beres, and Jay Lee and Debbie Humphreys. And really, the work that they've pulled together has been extraordinary and a ton of fun. Project RISE is the second protocol, and that's in 5 jurisdictions. It's led by Russell Brewer out of Chicago and Debbie Humphreys. So their work is in Cook County, Illinois, in Baton Rouge, Louisiana, in San Diego, Missouri, and Alabama. So you can see that there's quite a bit of diversity in terms of the sites represented. And finally, the third protocol is a sister protocol in which there's 2 different protocols, one focusing on FQHCs, rapid prep implementation FQHCs, and one focused on rapid prep within community-based pharmacies. So the first protocol there is led by Letitia Lopre out of UAB, and the other protocol is led by Chris Kemp and Gabriel Wagner at Hopkins and UCSD. So essentially what we have is created very organically out of this hub structure is a manual for procedures and leadership led by Sten Vermund, who has experience from chairing HPTN in the past, and we've had a lot of leadership and support from Nanette Benbow and Brian Mustansky out of ISKI. And then we've been drawing from the different hubs in terms of site PIs and sub-team chairs. The funding has been really minimal to date, so we've really been leveraging the resources of the hubs with NIH's permission, thank you. And lots of late nights from the investigators in terms of trying to really efficiently leverage resources to be able to answer questions on a broader scale. So at the moment, we're just getting into this piece of research dissemination because these projects are relatively nascent, but hopefully you'll be starting to see more results come out soon. And I think one of the advantages of this network is that we are learning quite a few lessons about how to do things efficiently, and we could talk quite a bit more about that. But we're building an infrastructure of shared expertise and shared technical skills in terms of implementation science, but also a lot of shared knowledge and community partnerships locally, as well as infrastructure to share data across the hubs and ISKI network. So what do we think that we can potentially achieve with niche? And so I'm going to try and draw from some ongoing data that are coming in from across these three protocols to give some ideas of what we think is possible. So first of all, we think that the data that are coming out of this network potentially can that speak well to this question about context versus generalizability. So we know that context is absolutely critical in the role of implementation, right? Conditions in one setting are very different than conditions in another setting, but and measuring and understanding how these influence implementation effectiveness is essential to achieve buy-in locally and help advanced implementation of evidence-based interventions. We also know that where we can start creating understanding across multiple contexts and pulling that data together to create generalizable knowledge, we can improve the speed of evidence translation and ideally help reach EHE goals more rapidly. And we really feel that niche is well positioned to both help improve the understanding of local context, but also improve our understanding of generalizability and increase efficiency and transportability of results. So as an example, these are data from 002. This is the study that I mentioned that's led by Russell Brewer and Debbie Humphreys, Project RISE. And this study is focused on trying to optimize community health worker-led status-neutral strategies out of community-based organizations. So they're working in, 5 pretty policy diverse sites: San Diego, Chicago, Louisiana, Missouri, and Alabama. And while they're collecting their data, what they are seeing is, although there are many differences across these sites, and you might not necessarily expect them to have a lot of similar lessons, of course there are things that are arising that are very comparable. And fair funding for community health workers has been just resoundingly coming through across the 5 sites as a critical area to tackle. And so even though these sites are all very different, strategies that are starting to address this fair funding issue could be tested potentially across multiple sites. And of course, there were many differences as well. So there's a recognition that in San Diego, folks really felt that limiting caseloads was absolutely essential to be able to implement community health worker-driven strategies, whereas in Missouri, folks felt being able to leverage their telehealth systems to have expanded reach was particularly important. Chicago felt data-informed systems were necessary, and Alabama felt that there was a lot of work that needed to be done to prioritize clients' perspectives and address some of the historical context of Alabama for implementation. Within 001, and this is work that's being led by Alethea Zamantakis, a new faculty member within the ISKI Hub. And what we found there by talking to local health departments across the 6 jurisdictions for our Rapid Start study. So our study is really trying to optimize Rapid Start for both ART and for PrEP using a status-neutral lens. And what we found by reviewing EHE plans and talking to health departments is that, first of all, there's no common definition for Rapid Start, right? So first here in bold, looking at rapid ART, you can see that for Alabama, that's within 7 days of diagnosis. With Chicago, there's no standard definition. For Dallas-Fort Worth, initiation within 72 hours. LA, 0 to 7 days, et cetera, right? So this is important, we think, because if we're trying to identify strategies that could be tested across contexts, we need to understand that even locally, the context of what is considered rapid start for ART are different. And similarly, these findings hold for PrEP, that in many places there is no standard definition of what is considered rapid PrEP or what we're often considering same-day PrEP. But despite many of these differences, we do see that there are opportunities for shared strategies. And as an example of this, in terms of what is going on in terms of implementation, we delivered a survey to Ryan White-funded clinics across these 6 jurisdictions. And what we learned here is that in terms of rapid ART, in fact, for the most part, there was quite a bit of consistency in terms of the proportion of clinics that were implementing rapid ART. Now, Alabama is a little bit of an exception, but for the most part, you see relatively high rates of adoption across these Ryan White clinics of rapid ART, and for this, we provided a uniform definition. For status neutral, although the numbers were lower, we did see that quite a few clinics reported implementing status neutral approaches as well, something that we're continuing to follow up in some focus group discussions. Rapid PrEP is where we saw a lot more heterogeneity, and that's perhaps not surprising given some of the constraints of utilization of Ryan White funds for PrEP. And so that's an area that if we're planning multi-site studies, we recognize there's going to need to be a little bit more tailoring potentially. The second thing that we think that niche can really start to help us answer and address is the power in numbers. So in a lot of clinical trials, the participants are patients or clients, right? And so from that perspective, working in a couple of clinics can be sufficient. But in implementation science, what we're often targeting are providers, clinics, community-based organizations, and it's hard to sometimes get enough of those clusters or units in one location. And so by being able to draw on not only the networks of multiple investigators, but multiple sites, we can be testing strategies across multiple locations and clinics. And we also have recognized that having multiple jurisdictions represented can increase representation across groups, which maybe within one jurisdiction may be smaller, but across multiple groups, multiple settings can ensure that there's a larger representation of groups for equity. In terms of some of these elements of power by number, power in numbers, you can see here that we sort of created a heat map from some of the early key informant interviews across health departments in the 6 jurisdictions of 001. And here you see that there's sufficient sample of different contexts to support generalizability. We can start identifying where there are consistency in messages and services offered, facilitators and barriers, and where there's heterogeneity. You also see here that in terms of representation, these are the clients that Ryan White clinics are serving across the 6 jurisdictions. By having multiple sites and multiple locations, we're able to ensure that there are diverse populations that are represented. Similarly, within a single site, there may be only a few FQHCs or community-based organizations that are represented, in this case within our Ryan White clinics, but by pulling multiple sites together, we can start to see trends within multiple different types of clinics. And we see that, clinics that are most likely to be implementing rapid PrEP are those out of FQHCs, whereas the community-based organizations are those that are really helping to lead the way in terms of status-neutral implementation. So although there's only, in this survey, 38 clinical organizations represented, they represent 52 clinics, and they're reaching about 29,000 prevention clients and 49,000 people living with HIV. So again, these small investments can have larger effects when you think about how many different individuals can ultimately be reached with strategies targeting those clinics or community-based organizations. This is a slide from Roxana Rezai, a PhD student here at UCLA. And what she's also been able to do is leverage this multi-site network and work with the quantitative team to develop auxiliary data to layer onto this network. So adding in data on walkability, employment, public transportation, health insurance, education. Again, this idea of being able to sort of leverage these big data along with the data that are being collected across these networks to be able to answer questions that are relevant for equity. From Project RISE, the study led by Russell Brewer and Debbie Humphreys, they're working again across 5 jurisdictions, again, very diverse jurisdictions. And what they've been able to identify through their qualitative work are some of the key strategies that they think should be going forward for testing for community health workers and status-neutral approaches. And things like organizational policies and practices, funding-focused strategies, data systems, these are things that have emerged. But again, these are things that aren't really going to emerge from a single site, right? When you're talking about policies and organizational policies and funding systems, being able to leverage multiple sites is really necessary to be able to gain these insights. I won't spend much time on this because Reva Datar presented beforehand, but the hub model was leveraged for this work with community and academic partners as well, which she presented earlier. And again, being able to sort of draw on this network of investigators and sites to be able to reach more partners than maybe a single site would be able to do. Finally, we believe that niche can help us develop and test implementation strategies with a focus on effectiveness and equity. The idea of being able to understand and prioritize across contexts. By being able to do that, we can both identify strategies that can be broadly delivered, but also identify where the priorities are different and where things need to be tailored. So I'll give a couple of examples of that quickly. So these are data from 003 from Leticia Alopre and team. The goal of their study is to understand key determinants to implementation of same-day PrEP in Medicaid expanded and unexpanded states. Again, so they're working across multiple contexts. And they've done some rank ordering of the most effective strategies from the perspectives of key stakeholders locally. And what you can see is that although these 5 locations are quite different, and they have both Medicaid expansion and non-expansion states, you see that across the sites, the number 1 and 2 strategies that were recommended locally to improve rapid PrEP implementation, same-day PrEP implementation within communities is leadership buy-in and PrEP champions. And those are strategies that can be tested and can be implemented in both Medicaid expansion and non-expansion states. There are some strategies that are much more tailored to specific locations. You can see number 11 and 12 highlighted, the mobile units, the telehealth. These are strategies that might be particularly important for rural areas, but by being able to understand across settings what the priorities are, we can start identifying what things can be tailored, can be tested across settings, and what strategies might need to be tailored to local context. Similarly, in our 001 protocol, we've been looking at the barriers to rapid ART and same-day PrEP implementation within the Ryan White clinics. And what we can see is that existing clinic workflows, availability of staffing resources, and clinicians' comfort providing ART or PrEP without full lab results have been real barriers for both rapid ART and rapid PrEP, same-day PrEP, to implementation. And we think this has, those are strategies that could be targeted to facilitate status-neutral approaches. We do, however, of course, see some differences in terms of the barriers. So there's some different barriers for PrEP that we would anticipate: insurance coverage for provision of same-day PrEP, lack of patient interest, and that's going to, particularly within Ryan White clinics. So those are barriers specific to PrEP that status-neutral approaches would need to take into consideration. So in terms of developing and testing these strategies, I think some of the big lessons that we've learned, at least in the first protocol, are that the data can defy expectations and help us unpack mechanisms. So because implementation of PrEP within Ryan White clinics is less common, and there are some funding constraints or creativity that is required, we believe that advocating for PrEP integration would be necessary to advance status neutral implementation. But what we've recognized through our qualitative work to date is that, in fact, this is not always the case. And in fact, what we've seen is that often it's local policies that are putting forward status neutral policies and recommendations that have pushed forward implementation of PrEP locally. So in fact, it was sort of counter to what our hypothesis was. There's been other assumptions about the universal good of status neutral approaches that have been uncovered. So although that's something that is often promoted, there are some concerns within the community of people living with HIV around the threats to limited resources and whether or not they really think that this is the best way forward. And that's something that we're continuing to unpack within this protocol as well. We've also recognize that there are some more rare or inconsistent within site findings that probably wouldn't have achieved prominence unless we were looking at them more broadly across sites. So 3 jurisdictions identified a lack of wraparound services and holistic approaches for priority populations as a barrier. And these issues around needing more services that are tailored to specific populations, those sort of came off as one-offs within sites, but when we were looking across sites, we found that, in fact, really thinking more carefully about how to design specific strategies for the subpopulations will be necessary because they're emerging across the sites, even if the numbers are smaller within a site. So in conclusion, in terms of what we think is the value of niche and recommendations going forward, this has been an organically built infrastructure and framework, but we do believe that the tools and the data harmonization, the shared expertise, we believe it has a lot of value to support CDC, NIH, and local health departments in terms of guideline development, implementation, prioritization, and research prioritization. And it also provides us the ability to sort of nimbly adjust research questions across this network of expertise. In 001, when we identified that we needed a little bit more, there was a little bit more heterogeneity in terms of the understanding of status neutral and the implementation maps of status neutral across sites, we've been able to adjust our protocol and really focus some of that on the status neutral approach. One of the things that we think is really nice about this network is that it provides a lot of opportunities for early stage investigators and mid-career professionals, and not just those that are a little bit more senior and already established. And it really gives a lot of weight to those investigators that have close ties with community health departments and community partners. So we think this is an efficient model that also is one that will help create the next generation of leadership in implementation science and HIV. So finally, in closing, the EHE initiative has identified, that the time to act is now. There's a lot of energy behind trying to achieve EHE goals by 2030, a lot of recognition that the tools are available. And we think from the perspective of niche, what we have is an opportunity to increase generalizable knowledge and reach, and we can do this very rapidly within this existing infrastructure. We have experience from a broad array of both clinicians, but implementation science experts, and bring a lot of technical expertise. So thank you very much for your time, and happy to answer a few questions.
Hello, my name is Glenn Stefferson. I'm with Empower You Community Health Center in Miami-Dade County. I don't want to be too sarcastic or blunt, but I want to address one issue, and that's the stigma. I hear a lot of money. I've been here for the 2 days, and I've heard a lot of talk and money being put into research, and I'm going to say it, trying to say the right thing without offending anybody or being disrespectful. Okay, but I'm in a room full of a lot of smart people, a lot of good stuff being said and a lot going on, but I'm the guy that's the support guy that takes the results of these researchers and go out on the street and attempt to implement it. And when we're talking to people about PrEP, taking an HIV medication, the first reaction that I get from them is it's negative. And it's because the stigma is still attached to the medication. And so just as the pharmaceutical companies are spending money to say it's okay, as an example, every other month, Cabenuva, there's commercials and everything. And when I see the health departments around the states say something about HIV, it's just a one-line billboard. And where I'm going with this, has anyone considered addressing the stigma with public address announcements, commercials on TV, other than just the pharmaceutical companies? Okay, spending money. There's a lot of money spent, because when I'm on the street, I'm the guy that goes out on the street to talk to people about PrEP. And like I say, the pushback that I'm seeing in the numbers is because the stigma is still attached to the medication as well as the virus, okay? And I don't hear anything being said about eliminating the stigma. There's a lot of good talk here, a lot of good things being done, but I have not heard anything about the stigma. And the stigma is what's killing people. It's what's hurting people. The stigma is what's keeping folks from wanting to take PrEP. And I've raised 6 kids. People are having sex. The young man here yesterday talked about black men in his barbershop. You say HIV or medication in them, they don't want to hear it. That's because the stigma's attached to it. The panel yesterday, a young lady got up and talked about PrEP in the Department of Corrections. The bottom line to that is people are having sex, even in the jails.
Yep.
Okay? And if that's the case, and I know this, and I put condoms all around my house, I raised 4 boys out of my 6 kids, and I have a whole lot of grandchildren. So people are having sex. And that's just it. But I'm not hearing, and I'm gonna wrap it up. Has anybody ever thought about putting money into letting the public know it's okay to take an HIV medication? You know, parents having a conversation with their children about taking an HIV medication, that if you're going out on a date with your friends, it's okay. Or you can say, I'm good, I'm on PrEP. You know, positive messages like this to the public. Because when you give it to the outreach worker or the HIV tester and counselor, which is what I do, and we try to talk to someone about PrEP, and some will listen. A lot of people do listen. But then they go, I don't want to bother with that. You know, and again, it all comes back down to the stigma. So I'm going to end it up saying I'm going to stand my ground as a big brother, because that stigma killed my little sister. And that's why I'm here today. Amen? But that's the question. Has anybody considered putting any money or addressing the issue of the stigma?
Yeah, it's a great question and an important point. I would just say that, you know, I think there are quite a few, I mean, not enough, but there are protocols and there are studies that are looking at that. I think there's growing recognition that there's a need to demedicalize PrEP and destigmatize PrEP. You know, I think that you heard the PrEP for Teens yesterday, and I think that was a good example of some initiatives going that direction. I think the community health worker strategy in the 002, that second protocol, working with community-based organizations, the work of a community health worker can help to, as you've been doing, as you know, help to destigmatize PrEP. I think that there is a need for testing of more strategies to change social norms around PrEP, stigma more broadly. So absolutely, it's a point well taken.
Thank you.
I Thank you, Glenn. My name is Jim Pickett from Chicago. I just thank you so much for those great comments, and it kind of sets up what I wanted to ask about. So you talk about, there's been a lot of talk about status-neutral approaches all over the place, and you shared some data and some assumptions that are being tested, that it's sort of a universally loved approach, that there are positive people like me who, not personally, but positive people like me who are concerned about what this means in terms of their care. And I've certainly heard that from positive folks. We're organized, we're a defined group. When we think of HIV negative people, that's everybody. They're not organized, thankfully, and they're not defined, they're all over the place. And working on PrEP for Teens, I think about status neutral approaches and what do we know about negative people's opinions about status neutral. They're not defined by a status. They're not living their life as an HIV negative person. That's not the highlight, that's not the headline necessarily, or a PrEP user. So I'm just wondering, what do we know, whatever our assumptions seem to be, this is good for everybody, but what do we know about HIV status neutral approaches from the context of a HIV negative person, many of whom I know aren't interested in walking into a Ryan White clinic. Anything that says HIV or AIDS, to Glenn's point, not interested. Not for them because they're not HIV positive. So any thoughts on that, or what do we know about that, and is there any work happening to find out more about the HIV negative community thoughts on status neutral approaches?
Yeah. A great question, one I'm also interested in the answer in. We do have, as part of our protocol, we haven't gotten to this stage yet, but we will have, we have some in-depth interviews planned with both those living with HIV and those who aren't living with HIV to ask some of those same questions, because I think you're right, that it's not just, potentially, it's not just that there might be concerns amongst people living with HIV, it's also that those who aren't living with HIV may not identify with the status neutral approach. So it's definitely something that we're planning on looking into and interested in, and I think those are the data that we need to bring back to really make sure that the strategies that are being proposed really make sense for the populations that they're meant to serve. Thank you.